Yay, we're live. Decisions. Bad choices. I'm going to go ahead and start this. Since I sent you an invite, Miss D. And go ahead and start this cardiac output. Slide 1. Cardiac output. With the blood pump by HR or heart rate. Just a stroke volume. It's 4 to 8 LPM. Through our heart about once every minute. As to increase cardiac output, the stroke volume, or increase the heart rate, or increase both. And it looks like the muscle have the highest exercise distribution of cardiac output. That is during exercise. Rest seems to be the liver, kidney, the brain. Okay, slide 3, cardiac output. We have decreased cardiac output, which leads to hypovolemia or left ventricular failure. Cardiac output, which can lead to hypervolemia and hypoxemia. Cardiac output, decreased cardiac output, leads to hypovolemia, left ventricular failure, to hypervolemia or hypertension. metabolism. Then we have cardiac index. Output corrected for body size is the cardiac. A more accurate parameter to monitor it takes metabolic rate and eliminates the effect of differing body size. Example, the individual and Arnold Schwarzenegger have the same cardiac index. One of them has a problem. Cardiac index is 2.5 to 4. Tissue oxygenation is compromised if it drops below stroke volume. Measure all components. Afterload and contractility. Be approximated by the pulse pressure. Pressure, the greater the stroke volume. Equals 2 milliliters times the pulse pressure. WP gives an estimate of preload. Tells you the afterload. Can't be measured by can't be measured, but can be approximated from the SI, which is the SD. Low contractility. Negative phenotype. Action. Ejection fraction is a ratio of stroke volume to end diastolic volume. What was available compared to what was squeezed out? 60 to 75. It can be determined by echocardiac. The ejection equals the SV divided by the ED. Volume divided by graphs, stroke volume. We have the SV volume. And we have the ejection SV divided by E. And then it says reached at filling. And we have another figure, circular and diastolic x-axis with the stroke volume on the y-axis. Here. Then measure output. Thermal dilution method. A specific quantity of injected rapidly into the PA catheter. The opening of the product. Cold solutions blood flow to the tip of the PA catheter store. No steps to reach the cardiac output. There, the higher the cardiac calculated from the amount of temperature change at the fix to get the catheter. Okay, your 1761, which is the system for measurement of cardiac output, which connects to the spike, which goes through the injecting to get to the syringe that has to connect. You have flow through how it connects to the IV string, which we have a three-way stop cocking. Then you have to the IV, and that connects to GAN's, which has balloon inflation valve as well as a thermistor connector. A proximal injects to the thermistor balloon, and then the catheter connects to the temperature, and the both of them connect to the catheter connecting to, which connects to the plate computer. Method. If no shunt exists, then the output for the R ventricle will be the same as the output for the L ventricle. This, though, CO measurement will not be accurate. Also not measured by standard CO measurements. Regular more regurgitation, the more inaccurate the CO measure. Then take a small pause. Stuff over. Okay. Step 11. We have measurement. We have V, which equals VO2 divided by 2 minus and igneous blood gas and an calorimetry, but accurate CO low CO. Dye, which a bolus of dye is inserted. At the same time, a continuous blood gas constant rate until dye is seen. Is the CO from the concentration of dye at the time it took the dye to reach the artery. In lab, but not in clinical practice. Then we have this velocity flow through the aorta. This graph, the area under the curve is the stroke volume. Okay. Performs CO measurement in / EF catheter with CO catheter. EF catheter, a special PA catheter that has response thermos to give a body PA temperature. Its bullet is inserted just above the tricuspid. The EF is calculated every 4. Thermal dilution / EF catheter. We have a special PA catheter that has a rapid response thermistor that can give a beat by beat variation in PA temperature. Then we have a cold injectate, which is inserted just above the tricuspid valve, and the EF is calculated. Continuous CO catheter. Dilution principle, the measurement is from a central venous line to a central arterial line. Absolutely. It requires a companion computer. Is a system that can derive CO from a conventional arterial line into the continuous CO. With CO catheter uses the thermal dilution principle, central venous line to a central arterial line, axillary, companion computer. It also says a newer invention is a derive CO from a conventional arterial line into the continuous. Then you have a diagram on slide 13. Catheter kit supplied by Pulsion Medical Systems AG. CVC, central venous catheter, of course, thermal dilution catheter, which is kind of sort of at thigh. Measurement, thoracic bioimpedance. Okay, so changes in contract developed by NASA. Electricity, but blood does. All the blood volume is lower and not flowing, so impedance is increased. Blood volume is higher and it's flowing, so impedance decreases. Information velocity. Okay, again, thoracic bioimpedance. In conductivity of the thorax, developed by NASA. Air doesn't conduct electricity, but blood does. Blood not flowing, so impedance is increased. Blood volume is higher and it's flowing, so impedance decreases. And calculates EJ and SV. Then we have a graph of the human upper, uh, the head to the lower, to the, from the upper torso up to the head. Graph of the vena cava and the thoracic aorta. And it shows where the HF measurement and the TB and ECG sensing. CO measurement, Doppler ultrasonography. This is a sound wave is bounced off the blood into the aorta to measure aortic diameter. The aorta causes a Doppler shift in the frequency of the returning ultra wave. Measurement of the cross-sectional area of the aorta multiplied by the measured velocity to that area, and HR gives the CO. 45 minutes to do. Sonography. Off the blood measure aortic diameter. The blood velocity through the aorta causes a Doppler shift in the frequency of returning ultrasound waves. Cross-sectional area of the aorta multiplied by the measured velocity flow through that area, and HR gives the CO. It's to do. Okay. Now we have a graph that shows the advantages of the method, which has the advantage that it's most accurate. CO is low. Requires steady state. Now, it's time consuming, involved risk of infection, and it's the least high. Then we have dye dilution. Only main advantage is that it's most accurate with high CO. Have disadvantages: shunts, allergic reaction to dye, personnel required, time consuming, blood withdrawals involved. Requires a steady state. The CO is low. Dilution, which main advantages withdrawal involved. It's easy and quick, and it's inexpensive. The major disadvantages is that it's invalid with shunts. CO is low. Then we have the Doppler method, invasive outpatient procedure. The disadvantages of that is experienced personnel required, it's time consuming, not easy to repeat, accurate with follow-up. Anemia, tachycardia, sub-Q or sternal incision. Bioimpedance, which the major advantages of that is that it's continuous CO risk and it's cheap. The advantage is that it's inaccurate following. MI, hypertension, shunt, regurgitation. Okay, now we have cardiac high CO, but can lead to burns, hypermetabolism, CO. It can lead to tissue hyperfusion, blood pressure because of vasoconstriction. Low CI, which says anything that decreases the CO will decrease the CI. change, but not as fast as CO. CO can lead to sepsis, burns, hypermetabolism. Low CO has tissue hyperperfusion and may have a normal blood pressure because of vasoconstriction. Cardiac index, low CI, the CO will decrease the CI, and yes, they can change, but not as fast as the cardiac output or CO. After the mean resistance of all the arterioles in the systemic circulation. Have a muscle layer that can constrict or dilate to keep blood flowing to the body. Heart equivalent of the SVR, which the right ventricle has to pump. BP is determined by the CO and the SVR. If the CO drops, the SVR will increase to try to maintain the BP. BP can't be used to determine early clinical changes in hemodynamic status. So the body can no longer compensate that the BP becomes significant. In other words, by the time you see the BP changes, hemodynamic effects are profound. BP is determined by the CO and SVR. The CO drops, the CVR will increase to try to maintain the blood pressure. It can't be used to determine early clinical changes in hemodynamic status. The body can no longer become significant. In other words, by the time you see BP changes, the hemodynamic effects are profound. SVR. By calculating SVR, you can tell if the blood vessels are constricted or dilated. Equals constriction equals dilation. Knowing this, therapy can appropriately be applied. To patients with a BP of 110/80, one has a high SVR. What are they doing? One has a low SVR. Why should they get a vasopressor? Okay, again, SVR. By calculating SVR, you can tell if the blood vessels are constricted or dilated. SVR associated with decreased SVR associated with dilation. Therapy can be appropriately applied. The example, two patients with a blood pressure of 110/80, one has high SVR. What are they doing and why should they get an inotrode? One has, no, wait, yes. The time is on the microwave. Low SVR, what are they doing? Why should they get a vasopressor? Nitropuricide rapidly or nitride rapidly decreases SVR and therefore BP. Hemop decreases SVR in patients with severe HTN. ACE inhibitors vasodilate. Have a low SVR. And then levofed, neosynephrine, dopamine. Try treatment. Yeah, we have ISVR is treated with nitropuricide or nitride, rapidly decreases SVR and therefore the blood pressure. Some decreases SVR in patients with severe HTN or hypertension. ACE inhibitors, which vasodilate. Low SVR, fluid bolus. And it's treated by low SVR, fluid bolus, and neosynephrine, dopamine. We have here that shows L, the y-axis. It has the 4 quadrants, and it's describing hemodynamic equilibrium. Far right, bottom or top quadrant, we have tension. In the core quadrant just below that, but to the far right, we have hypertension and cardiac insufficiency. F, lower quadrant, we have cardiogenic shock. Upper quadrant, then we have a couple more graphs here. It looks like a case study, case 1 degree, I guess. Cardiac insufficiency. Treatment, diuretics and nitrates, cardiac output at rest is /MS. Necessary treatment prescribed, digitalized results. Treatment of stroke volume plus 40% as well as leading to a left cardiac work index. Vascular resistance index due to the reduction in blood pressure. Number degree 2, tension, this is patient without treatment. Diltiazem and diuretics. Results after 45 days. Marked reduction of blood pressure and peripheral vascular resistance index as well. Of left cardiac work, no change in myocardial. Then we have slide 20 as emergency unit of a general hospital at night. No patient file or data. Clinical assessment unclear. About 80 to 55 mmHg, 120 beats per minute. Dynamic status assessment. High cardiac output index. A very low vascular resistance index and more or less normal left cardiac work index. Septic shock. Displays a low index with very low stroke volume. Resistance index, work index was in favor of a cardiogenic shock. Okay, critical care monitoring, mean graph. The y-axis per minute and cardiac index times 10 per minute. Well, liters by M2. And you have your heart rate on top with the butyramine perforation index with the same thing. And time is on the x-axis. Okay, pulmonary arterial for use differentiate causes of fluid status changes, function, intervention, and therapeutic air embolism. Patient defect, prosthetic cardiac pacemaker, severe vascular diagnosis, pulmonary hypertension, significant immunodeficiency, staff. Pulmonary artery catheter, indications for use. Causes of fluid status changes, assess cardiovascular function, assess shock, therapeutic aspirate air embolism. Contraindications, we have severe coagulation defect, severe vascular hypertension, deficiency, and untrained staff. Now, slide 30. Testing, 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 testing. Okay, good. insertion into the external or internal jugular vein. But cubital tell you where catheter tip is located. Wire sheath punctures the vein. The catheter is the vein over the guide wire. Then the guide wire is moved. Catheter is pushed C/RA area. Away from the SBC/RA, the balloon is inflated and the catheter floats through the heart to the wedge position. That does not sound pleasant. Usually inserted into external or internal jugular or subclavian vein, but antecubital size can be used to tell you where catheter tip is located. Wire sheath punctures the vein. The needle is removed and the catheter is fed into the vein over the guide wire through the sheath. So the guide wire is moved into the SBC/RA area. You know you're there by the waveform and the distance. CRA, the balloon is inflated and the catheter floats to the heart. I'm going to take a small this way. Okay. Now, go use that. Waveform in regards to catheter placement. Okay, slide 31. Graph that shows hearts, 4 hearts. The catheter is, oh my God, they all look painful. Okay, here's 1758 normal values and wave configurations produced by the pulmonary artery catheter. Two, pulmonary artery catheter complications. Hernias, catheter kink or catheter clots, pneumothorax, pulmonary infarction, catheter whip from movement. Again, pulmonary artery catheter complications, we have arrhythmias, catheter kink or catheter knot, clots, pneumothorax, pulmonary infarction, movement, and balloon rupture. Slide 33, we have tap pressure. Systemic for two reasons. The lungs are close to the RV, so it doesn't have to pump the LV. Less pressure is needed to push blood through. And gas exchange would be impeded if high because intravascular pressure would push fluid into the alveoli. Okay, slide 34, we have a pathway form. As a systemic arch lower pressures. See what else? It says electrocardiogram, pulmonary artery width. Waveform can be correlated with the activity of the right ventricle and the corresponding pressure of the pulmonary artery. Phase of the pulmonary artery pressure reflects right ventricle. Therefore, the systolic rise occurs after the QR flex on the ECG. And on slide 35, waveform. This occurs as the RV ejects blood into the pulmonary artery. The peak of the anacrotic rise of the pulmonary system occurs after systole and includes the dicrotic notch. The bottom of the dicrotic limb is the diastole. Again, we have a path that says the anacrotic rise occurs as the RV ejects blood into the pulmonary artery. Rise systolic blood pressure. Dicrotic occurs after systole and includes dicrotic notch of the pulmonary valve. And then last of the dicrotic limb is the diastolic blood pressure. Slide 36. Systolic and pressures are about the same. All the pulmonary valve is open. Systolic is diastolic because of the resistance of the blood vessels in the lung and because the pulmonary valve is closed during diastole. Normal value 25 systolic / 60. Increased systolic pH Factors that increase the pH systolic system: pulmonary embolism, ARDS, COPD, hypertension. Again, increase systolic PA pressure, PA systolic embolism, hypoxia, COPD, and pulmonary hypertension. '38. PA diastolic pressure. Increase pulmonary systolic pressure plus. Vascular volume overload. Function of any cause, myopathy, and cardiac tamponade diffusion. PA diastolic pressure. All factors that increase pulmonary systolic pressure plus. Volume overload. Function of any cause, restrictive cardiomyopathy, and diffusion. Now we have decreased PA, systolic, and diastolic. We have 3 bullets here: hypovolemia, severe tricuspid, severe pulmonary valve stenosis. We have 3 bullet points under the decreased PA, systolic, and diastolic: severe tricuspid stenosis, and severe pulmonary valve stenosis. You have 2 sections. I have 2 hearts in each. You have one showing normal stenosis, the other one showing pulmonary stenosis. Looks like is that the tricuspid valve, that area, that chamber is a little bit, it looks like it's not enough. The valve is kind of closed. Because it's hardening. Stenosis is the hardening of the wall. The pump stuff and the tricuspid valve, and then the pulmonary stenosis that goes to the pulmonary valve. So, okay. 40. Alterations in the waveform. Pressure will be narrow in tamponade or shock states. This says pulse pressure widens with significant septal defect. And then we have a diagram for med states. The diastolic pressure and pulse pressure on the y-axis, augmentation pressure. And shooting the PA catheter, the transite, it will give a false low reading of PA pressure. Let me make sure. Testing. Okay, so if the transducer is too high, it will give a false low reading of PA pressure. If it's too low, it will give a false high variation. slash ventilator will cause the waveform to fluctuate. Like the transducer is too high, it will give a false low reading of PA pressure. Transducer is too low, it will give a false high reading of PA pressure. The variation slash ventilator will cause the waveform to fluctuate. Reload. Oh, shoot. Just a second. Go back. While troubleshooting, damn it. Why do you keep doing that? Right. Right. Yeah, I tried it. Uh, John Michael, I'm recording right now. The transducer. Oh, shit, I'm bored. Okay. Still broadcasting, testing. Oh, come on. Don't tell me to stop. Don't fucking me. It's really making me angry. There it goes. Oh, yeah. Respiratory variations. Okay. Preload is the amount of blood in the left ventricle at the end of the diastole that is available to be pumped out with the next heart. Definitely. What is the preload? Okay. Preload, slide 42. Preload is the amount of blood in the left ventricle at the end of the diastole that is available to be pumped out with the next heartbeat. The fibers of the ventricle point, the greater the stretch, the greater the force of the contraction. Of overstretch, there is not enough overlap of actin and myosin for good contraction. So, load would increase at least until you reach the point of overstretch. Okay, then we have preload equals end diastolic volume. Okay. And then we have another graph here that says in the sensor it has ventricular preload. Atrial contractility goes up. I guess that makes the preload go up. Compliance goes up, the preload goes up. The venous pressure seems to go up, preload. Compliance goes up, is going to, I believe, that make a negative effect on the factors determining ventricular preload. A plus sign indicates that an increase increases ventricular and diastolic volume, and therefore preload. Minus indicates the variable decreases preload. Okay. Venous compliance, as it goes down, I guess it. And this is venous volume, total blood volume, respiration, muscle contraction, gravity. Then you have your inflow resistance, which as it goes up, it decreases the preload. Your outflow resistance and afterload, as it goes up, it increases the preload. And then your heart rate, as it goes up, it decreases the preload. So. The blood stress fibers are greater than force contraction strength start. how many more ago? 18, 19, 23 more. Preload is measured by the PCWP. WP is 612 mmHg. The wedge decreases with hypovolemia, vasodilator drugs. Decreases with hypervolemia, LV failure, ischemia, abnormalities, and restrictive pericarditis. Okay. Dang it. The preload is oh shoot. Slide. Okay. Let's see. Preload is measured by the PCWP, normal P 12 mmHg. The wedge decreases with hypovolemia or vasodilator drugs. Decreases with hypervolemia, which I believe is liver failure, ischemia, mitral valve abnormalities, and restrictive pericarditis. Preload. When the PA wedge, it reads PA pressure, which is reflective of the pressures of the heart. When it's wedged, it's measuring back pressure from the left side of the heart, because it indicates how much volume the heart has to pump. Too much volume, which can cause a backup of blood into the lung. Too little preload means there's not much blood to pump and cardiac output falls. Can occur preload is important because it why is preload of the preload? Michael, please stop spitting on the floor. When you spit on the floor, ain't no girl gonna marry a man that spits on the floor. No matter, ain't nobody gonna marry you if you spitting on the floor. It's gross. Hi, and if you listen to me,
I told him married you right
yeah, but you still gotta be maybe, but you gotta be clean, John Michael. Don't nobody like nobody that's nasty. Maybe, maybe not.
now. I'll be your best man for it. I'll be a worth it.
She is water, powerful enough to draw you, soft enough to cleanse you, deep enough to say, God, Angie, thank you. That's so sweet. I love you. Okay. Let me read this one more time. Preload. When the PA catheter isn't wedged, it reads PA pressure, which is reflective of the pressures on the right side of the heart. When it's back pressure on the left side of the heart. Preload is the volume the heart has to pump. Too much preload means too much volume, which can cause a backup of blood into the lungs. Too little preload means too little volume, so there's not much to pump, and the cardiac output falls. Okay, PCWP. When looking at the PCWP, wave and delay in transmitting the pressure from. You determine the value of the PCWP the same way you use the CP. Add the high and the low of the A wave and divide by 2. The wedge with the PA diastolic, although the wedge will be slightly lower. The balloon inflated for 15 seconds or less. Oh, dang. What slide was that? 45. How do you determine the value of the PCW? Bam. Okay, let's go over this one more time. When looking at the PCWP waveform, the A wave falls at the end of the QRS because they're the pressure back to the catheter tip from the left heart. The value of the PCWP the same way you do the CVP. Of the A wave and divide by 2. The wedge with the PA diastolic, although the wedge will be slightly lower. Only keep the balloon inflated for 15 seconds or less. Then it says decreasing the preload. Preload can lead to heart failure. The goal of measuring the PCW to CO delivery to the body. The easiest way to decrease the preload is to give a diuretic, which will pull fluid from the body. Venodilators will also decrease the preload. The vein expands, blood will pool in them back to the heart. Morphine and NTG, which I think is nitroglycerin, I know that. I did not know what this was. Increasing the preload. If preload is not enough, wait a minute, 547, repeating the preload. An elevated preload can lead to heart failure. The goal of measuring PCWP is to maximize CO and oxygen delivery to the body. These preloads give a diuretic which will pull. Venodilators will also decrease preload as the vein expands, blood will pool in them, returning less back to the heart. Here are examples of venodilators. Okay, increasing preload. If the preload is too low, there's not enough blood available to the ventricle, so the CO drops, and consequently, you may drop. What is the body's compensation to keep the BP from dropping when CO drops? This increase the SBI. To increase preload is to give fluid, crystalloids, colloids, or blood. Venoconstrictors will also increase preload. As the veins contract, they will push more of the blood in them back to the heart, and less will pull in the vein. Is an example. Venoconstrictors. Sodium. John Michael, stop it, please. You know I'm working. No example. Venoconstrictor, potassium, phenylephrine, and vasopressin are also venoconstrictors. Read that again, increasing the preload. If preload is too low, there is not enough blood available to the ventricle to pump out. So the CO cardiac output drops, and consequently, the blood pressure or BP may drop. What is the body's compensation to keep the BP from dropping when CO drops? The easiest way to increase the preload is to give fluid, crystalloids, colloids, or blood. Colloids or blood, okay. Also increase preload as the veins contract. They will push more of the blood in them back to the heart, and less will pour in the veins. Norepinephrine is an example. There's sodium, potassium, phenylephrine, and vasopressin are venoconstrictors. Now I know why they. And that is all. That's the final slide. this session. Testing. I hope